Good afternoon, everyone, and Happy New Year. I want to welcome you to today's Lunch and Learn webinar for the Iowa Pediatric Mental Health Collaborative, Growing Up with ADHD, Developmentally Informed Approaches and Considerations for Diagnosis and Treatment, presented by Dr. Molly Nikolas. My name is Kathy Dixon, and I'll be moderating the session today. I'll cover a few housekeeping items before we get started. The webinar will be recorded and made available for viewing on our YouTube channel. The link will be shared in the follow-up email after the session. Following the presentation, we will have time for questions. Please use the Q&A feature in the webinar toolbar to submit your questions, and we will cover as many as time allows. Instructions for how to claim continuing education credit will be uploaded to the chat section. I'll do that shortly. I'll also send this information to all attendees in the follow-up email after the session. So without further delay, it's my pleasure to welcome our guest speaker today, Dr. Molly Nikolas.
Thank you so much, Kathy. I'm delighted to be here. Thank you so much for the invitation. Today, I'm going to be talking about developmentally informed approaches and just different considerations for the diagnosis and treatment of attention deficit hyperactivity disorder. But before I get started, I wanted to just tell you a little bit about myself. I'm an associate professor here in the Department of Psychological and Brain Sciences. I am also director of the Clinical Science PhD program, the Clinical Psychology Training Program here. So I'm a clinical psychologist by training. My PhD is from Michigan State University. I also completed my clinical internship at the University of Washington School of Medicine, and specifically all of my clinical work was at Seattle Children's Hospital. I am the principal investigator of the Iowa ADHD and Development Laboratory. I've been at Iowa since 2011, and my research focuses on risk and protective factors for ADHD, specifically across different areas of development. So I'm very interested in the transition from childhood into adolescence, and then the transition from adolescence into emerging adulthood. The factors that my work focus on specifically include genetic and biological mechanisms, as well as cognitive factors, emotion regulation, and psychosocial processes related to the family environment. I am also a licensed psychologist in the state of Iowa. So I provide clinical supervision of our graduate students who are engaged in assessment and intervention work in the Seashore Psychology Clinic over in PBS. My lab is currently funded by the National Institutes of Mental Health and the Society for Research in Adolescence. And we have previously received funding from NICHD, the National Science Foundation, Shire Pharmaceutical, which is now Takeda, March of Dimes, and the University of Iowa Center for Injury Research and Prevention. Some of the work I'll talk about today is conducted in teams I know that are very important for research, and there's a picture of my team. Includes several undergrad, graduate, and postbac students who make really important contributions to all the work that we do. So you saw the learning goals for today's webinar. Today, after the webinar, you'll be able to identify developmental trends related to ADHD diagnosis from childhood through adulthood, evaluate recent innovations in ADHD diagnosis and treatment, and analyze their benefits and limitations. I'm going to review strategies for ADHD screening and diagnosis with a particular focus on primary care settings that are most relevant to you all. And I'm going to close by talking about ADHD in the 21st century, including recent work on what's been termed Cognitive Disengagement Syndrome and its relation to ADHD. And I'm going to make a few comments about ADHD in the world of social media, which has become a very hot topic in my world when it comes to things like self-diagnoses and where to get good information about the disorder. Before I get started, I also want to provide some context of how my approach is in dealing with these issues. I bring one type of expertise to understanding ADHD, given my background in clinical psychology, but I just want to acknowledge there are many different types of expertise when it comes to understanding this disorder. This includes the expertise of parents and teachers, physicians, social workers, nurses, and those with lived experiences. The other thing I want to point out is that people with ADHD are a really diverse group. There's a lot of heterogeneity. So many findings that I'm going to talk about today are based on groups of patients with ADHD, but those findings may not generalize to every single person. Right? The other thing I like to acknowledge is that a lot of the research that I do, a lot of the clinical interventions that I'm going to talk about today, often take a deficit-based approach to understanding disorders like ADHD. And what I mean by that is they focus really specifically on areas of weakness. From my perspective, I think it's approaches that can also build on strengths are crucial for supporting people with ADHD in order to help them achieve their goals and attain good outcomes. So I do my best to try to reconcile some of these differences, but I realize a lot of what I'm going to be talking about is going to be focusing on deficits and not as much on strengths. And as Kathy mentioned, please put questions into the Q&A and I'll try to go through as many as we can at the end. So in terms of today, I'm going to begin with some basic background information to define ADHD, to give you some relevant updated information regarding the epidemiology of the disorder, its correlates, and some information about causal contributors. But the majority of the time today, given some of the interests of this group, I want to focus on understanding different treatment modalities for ADHD, thinking about developmental considerations in both screening and diagnosis, as well as in treatment selection. And then I'll wrap up talking a little bit more about cognitive disengagement syndrome and some of the issues going forward to try to understand this disorder in the 21st century. So one thing that I usually tell my students when they're first starting to learn about ADHD is I think this disorder may have a bad name. Attention deficit hyperactivity disorder. People focus greatly on attention problems and hyperactivity, which are definitely symptoms of the disorder. But for me, I fundamentally frame this disorder as a problem with self-regulation. And to me, what this means is that these are individuals who have difficulty modulating their behavior in response to different types of environmental circumstances, right? So this is about how you match your behavioral response to the environment that you're in. The symptom dimensions of ADHD are two different correlated, so they're related to each other, but they are separable. The first symptom dimension reflects symptoms of inattention disorganization, and the second, hyperactivity and impulsivity. So inattention disorganization is defined as difficulties with focusing on tasks, following through on requests or instructions, and organizing activities. And individuals with ADHD have these difficulties across different contexts. So this can be at school, at work, or at play. Many individuals have difficulty with sustaining attention over time, particularly on tasks that are repetitive, very structured, and also less immediately rewarding. Now, there's been a ton of research, including research in my own lab, trying to essentially identify the attention deficit in ADHD. And it's pretty complicated because there's many different dimensions of attention that we can measure. There's work that's focused on attentional capacity, which is basically the amount of information that we can remember for a short time. There's also research on selective attention, or the degree to which we are prone to distraction, the ability to concentrate on relevant stimuli and not be distracted by task irrelevant stimuli. And people with ADHD have some mild impairments in both of those areas, but the main attention deficit that we tend to see that has the biggest effect is in what we call sustained attention. So this is the ability to maintain focus over time, right? To persist cognitively at a variety of tasks. And what we've learned through research in my lab and others in the field is that many of this is potentially due to an alerting problem in the brain, is in terms of the brain actually being oriented in order to recruit the different circuits needed in order to execute these tasks. The second symptom dimension of ADHD is hyperactivity impulsivity, which fundamentally is an inability to voluntarily inhibit and regulate ongoing behavior. This usually manifests as fidgeting or difficulty staying seated when required. In children, you may see a lot of moving, running, climbing, touching things, excessive talking, pencil tapping, very common. In adults, what you might see is people, even if they're not moving around, they will describe themselves as feeling very physically restless, or that they just have to get up and move. You may see excessive energy that is intense and appropriate, and most importantly, not goal-directed, which is an important distinction, particularly when you get into adolescence and adulthood, and thinking about distinguishing between hyperactivity symptoms and symptoms potentially of mania or hypomania. And so what we tend to see in people with ADHD is, despite all of this excessive movement, energy, and activity, they're actually accomplishing much less in terms of task completion, whether it's in the classroom, in the workplace, in activities. They're not getting as much done. And then the second element of impulsivity has to do with basically the ability to control or inhibit immediate reactions, or really to think before carrying out different behaviors. Now, impulsivity we can see manifest in a number of different ways. This may come across as cognitive impulsivity, which is sort of like hurried thinking or the inability to delay gratification. We may see behavioral impulsivity, particularly in younger children, difficulties with inhibiting responses when situations require it, running into traffic without looking, all those types of behaviors that we normally think about doing things without thinking through them all the way. And then emotional impulsivity, which sometimes doesn't get as much attention with ADHD, but we do see individuals have difficulties with patience, being able to tolerate frustration, having a quick trigger or a quickness to anger, or quickness to become more irritable. Those are also elements of emotional impulsivity that we see frequently. So in terms of the specific criteria outlined in the Diagnostic and Statistical Manual of Mental Disorders, there are 18 different behavioral symptoms. There are 9 inattention symptoms and 9 hyperactivity impulsivity symptoms. In order to meet diagnostic criteria, children have to have 6 or more symptoms in either domain. For adults, I just want to note that symptom threshold is not 6, it is 5 for individuals 17 and older. Those symptoms need to be present for at least 6 months, if not longer. Those symptoms need to have onset before age 12. And they also need to be noticeable in at least 2 different settings. So that could be at home, at school, at work, in leisure activities, but they need to be present in more than one situation. They also have to have a significant impact on social, academic, or occupational functioning, and they cannot be better accounted for by another mental disorder. Now, in the DSM-5, there are 3 different presentations of ADHD, depending on the kind of combination of symptoms that people are endorsing. So the first is called predominantly inattentive, which is defined as having 6 or more inattentive symptoms and fewer than 6 hyperactivity impulsivity symptoms. This is the same as what used to be called ADD, or attention deficit disorder. This is really describing primarily inattentive symptoms and few to no hyperactivity impulsivity symptoms. The second presentation is called predominantly hyperactive impulsive, which is just the inverse, that these are individuals that have 6 or more hyperactive impulsive symptoms and fewer than 6 inattentive symptoms. I will say from work in my own lab and in the research, we find this to be the rarest of the presentations, really most frequent in preschool children, potentially when they're in situations where the attentional demands are less. But we tend to see the rates of predominantly hyperactive impulsive presentations decline rapidly with age. And then combined, which I think is the most common type that we see in clinic, and is the most common type of the 3, which these are individuals that have both 6 or more inattentive symptoms and 6 or more hyperactivity symptoms. And this is definitely the most common type in childhood. Now, there was a lot of work leading up to DSM-5 trying to understand if these different subtypes or configurations of ADHD were meaningfully different in terms of their causes, their response to treatment, their correlates, and there were some differences. We do see that children with ADHD combined presentation are more likely to have problems with inhibiting behavior, with behavioral persistence. They're more likely to have co-occurring problems with aggression or defiance. They're more likely to face peer rejection, suspension from school, and to have learning difficulties. However, over time, what we found is these weren't really configural differences between the combined presentation and the inattentive presentation. It likely reflects the fact that the combined presentation is more severe because people have more symptoms. The other thing that's important to note is these presentations are meant to capture a moment in time. They are not necessarily stable over time or longitudinally. And this is largely because in most people, and particularly people with ADHD, we see a normative developmental decline in hyperactivity during adolescence and adulthood. So the most common developmental configurations that we see are individuals who had a combined presentation in childhood and then an inattentive presentation in adulthood. So I'm going to transition and talk a little bit more about epidemiology. When it comes to prevalence rates, generally the overall prevalence rates in North America range from about 5 to 9%. Here's a map of the United States. This is all based on parent reports. So these aren't necessarily full diagnoses. So these rates may be inflated somewhat. But you can see Iowa here has one of the higher prevalence rates in the US at about 11.5% of parents saying their child's has been diagnosed with ADHD. Worldwide, this is very similar. The rates are about 5%. And we see by adulthood, the prevalent rates worldwide are approaching 9%. ADHD remains, I think, one of the most common reasons that parents seek mental health supports for their children. About 50% of children referred to mental health clinics display ADHD symptoms, either alone or in combination with other problems. And it still remains the most common referral for both psychiatry and psychology. So it is definitely one in which prompts assessment and treatment most frequently. I also think it's helpful just to get a sense of the numbers and how this breaks down based on age and over time. So here in this top corner, I just plotted information about the number of children that are diagnosed with ADHD by age group. And you can see that preschool age, there's less than 1 million, about 265,000. By the time kids are 6 to 11, right now it's about 2.4 million, and then increases with age to 3.3 and then 8.7. So this is indicating that as kids get older, right, we're seeing more cases and we're able to identify them. The preschool age can be very difficult to identify kids with ADHD just because some of those problems with hyperactivity in particular and impulsivity are very developmentally common. The number of kids diagnosed ages 3 to 17 has not varied too much, although there has been an uptick over the last 20 years. You can see about 4.4 million were diagnosed in 2003. And the most recent data that I could find between 2016 and 2019 was right about 6 million. ADHD is a disorder that commonly co-occurs with many other mental health conditions. About 2/3 of people with ADHD will also have another behavioral or emotional disorder. In children, most frequently, this is a behavior or a conduct problem, but also frequently kids will present with anxiety and depression. Also, autism spectrum disorder and tics or Tourette's are also quite common. I do want to note that the types of co-occurring problems changes quite a bit across development. And by the time people with ADHD reach adulthood, the most common co-occurring conditions are anxiety and depression. Also not pictured on here because this was mostly data with children, substance use problems also become more prevalent with people with ADHD as they get older. Now, importantly, there is good news that about a half to 2/3 of individuals with ADHD do seek treatment, but the type of treatment that they seek or that they're offered varies quite a bit by age. So when we're looking in the preschool age, the vast majority of kids are being treated with therapies, different behavioral therapies, which I'll talk more about, and less so with medication. But by the time we move into childhood and then into adolescence, this flips quite a bit to where we see the most predominant therapies are medication. In terms of the course and outcome, ADHD is often identified usually in elementary school, kind of those kindergarten through grade 2 tend to be the most common times for identification. But we know that there's problems that emerge prior to that we can see indices of elevated hyperactivity and impulsivity in preschool. And there's people working on this now trying to identify unmeasured signs, even prenatally or at birth. So hopefully we'll be able to kind of understand some behavioral markers that might indicate risk earlier on. But generally, elementary school is when ADHD is identified. We also see disruptive behaviors tend to increase during this period. And again, many kids with ADHD may also have different learning or academic issues. As kids move into adolescence, some may experience a worsening of behavior problems and also increased anxiety and depression. Adolescents with ADHD often have deficits with things like self-care or personal responsibility, developing that autonomy, and can also have difficulties socially, in addition to ongoing issues with academic performance. And then in adulthood, we see that adults with ADHD, on average, have multiple impairments compared to adults without. These can be workplace difficulties. Adults with ADHD are more likely to have driving infractions, car accidents, speeding tickets, have more difficulties with managing personal finances, tend to have more difficulties with interpersonal relationships. Adults with ADHD are more likely to have relationships and are more likely to be divorced, and are also more likely to have legal problems or be incarcerated. We also see, again, increased substance use issues in adults with ADHD. In terms of gender differences, the the differences across males and females for ADHD is probably about 2 or 3 to 1, meaning that there are about 2 or 3 times more males with ADHD than females. But I do want to point out that this sex difference decreases with age. By the time we get to adolescence, it's about 2.5 to 1 favoring males. And by the time we get to adulthood, it's only slightly more common in males. And the big reason for this decline in sex differences is because females are identified later in development. So this is not because males are growing out of ADHD. This is generally because females are more likely to be identified when they're older. However, if you go into a clinic, particularly say child and adolescent psychiatry here or anywhere, and you look at the gender ratio in a clinic sample, it's going to be much higher, usually 6 to 1, sometimes as much as 10 to 1. And this is because boys are just more likely to be referred for assessment and treatment because they're more likely to have problems with defiant behavior and aggression. However, when girls display those same problems with defiance and aggression, they are actually referred for evaluation when they're younger compared to boys. And one thing I'll point out, and this is kind of a theme through where ADHD needs to go in the 21st century, is that ADHD in girls often goes unrecognized and unreported, particularly in childhood. And there's a lot of work, including work that we're doing in my lab now, trying to understand how the current behavioral criteria may be less sensitive to the types of problems that girls experience, girls with ADHD experience, particularly related to kind of emotional dysregulation or emotional impulsivity. And so many times when girls are presenting with these symptoms, they're often attributed to a depressive disorder, and they're actually more commonly diagnosed with depression. But we know that girls with ADHD are also more likely to display those inattentive, disorganized symptoms, which may not get the attention of a parent or a teacher, especially in a crowded classroom where there are other kids with more disruptive behavior. They may go unnoticed. However, when we look at longitudinally at boys and girls with ADHD do have similar symptoms. The causes don't seem to vary too much by sex, and the course seems to be pretty similar. But we do see girls with ADHD, particularly those that have high levels of hyperactive impulsive symptoms, or girls with that combined presentation, are at particular risk for different types of problems. We see those girls are at higher risk for disordered eating during adolescence, and are more likely to engage in self-harm or have suicide attempts during adolescence and early adulthood. And we know that girls are just less likely to be diagnosed in childhood and are actually being more frequently diagnosed in late adolescence or adulthood. So just to recap a few things about comorbidity, ADHD co-occurs with many different types of disorders. I've already talked about mood disorders. About 20 to 30% of people with ADHD have a mood disorder. There's also high overlap with bipolar disorder. About 25% meet criteria for an anxiety disorder, and this rate actually increases with age. About 30% also have co-occurring tics or Tourette syndrome. It does appear there is common genetic influences. One kind of myth in the field is that stimulant medications may cause tics or Tourette's. And what the research has really indicated is that it's likely they're not causing tics, but they're potentially making them more visible when they're on those stimulant medications. About 50% of kids with ADHD will also meet criteria for oppositional defiant disorder or conduct disorder, and they're also at risk for earlier initiation of substance use. And then there are all different types of difficulties that are more common in people with ADHD. This includes motor coordination problems. Asthma is much more common in ADHD, enuresis or nighttime bedwetting. An area of research that I spent a lot of time trying to understand is the risk for accidental injuries, that we see that kids with ADHD have about 3 to 4 times higher risk of having an injury that requires medical intervention than kids without. And we also see increased sleep disturbances. And most recent data has indicated that having a child with ADHD increases medical costs by 5 times over the medical costs of a child without ADHD. And it's likely because there are multiple different comorbidities that are quite common. So what do we know about causes? ADHD runs in families. About a third of the biological relatives of an individual with ADHD also have ADHD. And we see that the family load of ADHD tends to be higher in girls with ADHD than it is in boys. But we know that ADHD has a high heritability. This is where a lot of my research has focused on. About 75% of the variability between people when it comes to ADHD are likely due to their genetic differences. And we also see evidence of genetic effects from adoption studies that we see ADHD rates are about 3 times higher in biological versus adoptive parents of children with ADHD. In terms of the specific genes that are involved, there's been some implication of genes that influence the synthesis and dopamine neurotransmission in particular, particularly genes that might result in reduced dopaminergic activity. But there's also a variety of genes that are likely involved that influence kind of early neuronal growth and communication. Many of those genes are also shared with genetic effects for things like autism, schizophrenia, depression, bipolar disorder. So there may be some non-specific genetic causes that are increasing risk for things like neurodevelopmental disorders. There's been some work looking at epigenetic changes, whether stress can result in methylation that can increase risk for ADHD. And so some of that work is ongoing, and the findings have been less consistent, but there is a lot of interest in trying to understand whether there's epigenetic effects for ADHD as well. Notably, factors that can compromise the development of the nervous system before and after birth have been related to ADHD, although they're not specific to ADHD. But exposure to nicotine, alcohol, and other drugs during pregnancy increases risk, as does low birth weight. These seem to be contributing factors rather than directly causal. It is difficult to disentangle the influences of substance exposures from other genetic and environmental factors. And much of this is because mothers with ADHD are also more likely to use substances during pregnancy. There is one study, it's one of my favorite studies that's been done in the last 20 years, that actually examined the effects of prenatal tobacco exposure on ADHD in both genetic and genetically related dyads and non-genetically related dyads. So these were mothers that were pregnant through oocyte donation or embryo donation. And they found, interestingly, that the effects of tobacco only held when the mother and the child were genetically related. It was not related in the genetically unrelated pairs. And what that tells us is there's probably some genetically mediated mechanism that is linking exposure to these teratogens during pregnancy to ADHD. There's lots of brain research on ADHD that's documented some consistent findings. We see that people with ADHD tend to have an overall smaller total brain volume by about 2 to 4%, decreased size of the cerebellum, and also delayed brain maturation. There's interesting twin studies looking at identical twins who are discordant for ADHD, meaning one has ADHD and one doesn't. That has shown the brain abnormalities tend to follow the twin that has ADHD. And many of the functional brain imaging studies have shown lower activation in a variety of different networks, particularly networks involving kind of cerebellar prefrontal striatal networks. What we see in those studies is there tends to be an under-responsiveness to stimuli that leads to deficits in response inhibition. Different types of PET studies have also shown decreased blood flow to these prefrontal regions and in their connections to other parts of the limbic system. There's also other brain networks, particularly the default mode network that involves these different brain structures, the anterior cingulate, the posterior cingulate, and the medial prefrontal cortex that tend to be less well delineated in people with ADHD. And what we think that might mean is that they have more problems transitioning from resting wakefulness to task activity, right? So it's that transition from sort of going from idling to being alert and engaged, that those brain networks supporting that activity are less well connected. The known action of effective medications for ADHD are highly suggestive that different monoamines, dopamine, norepinephrine, and serotonin are likely involved in some way. And most evidence suggests that this is a selective deficiency of available dopamine and norepinephrine. This doesn't necessarily prove that these deficits are the direct cause of the behaviors, but this is where most of the medication interventions focus on. And then I'm going to talk more about this in interventions, but I just want to point out sugar is not a direct cause of hyperactivity or ADHD. There is some evidence, it's not well replicated, but there is some evidence that individuals with ADHD may be more sensitive to sugar. But there is potential role of food additives. That some food additives, particularly red dyes, artificial food colorings, may be associated with ADHD in kids or adults who are already genetically vulnerable. So we'll talk more about some of the diet interventions. But I do warrant caution about kind of miracle diets to cure ADHD, but there is evidence that some of these factors may increase risk for those that are already genetically vulnerable. Work in my lab has also identified low levels of lead exposure as being associated with ADHD, as well as other environmental toxins. We're currently looking at things like polychlorinated biphenyls and pesticides. Again, not primary causes, but they likely are impacting those that are already genetically vulnerable. And then when it comes to family influences, there's little support for explanations, causes of ADHD that are based exclusively on negative family influences. But we do see this likely moderates symptom severity. More frequently, what we see is that difficulties with parenting or family problems are the result of interacting with a child who is impulsive or difficult to manage. We see increased conflict in families where there's kids with ADHD, and that can be associated with the later emergence of more disruptive behavior problems. We also see that parents with ADHD themselves may also show less consistency in how they discipline or manage behavior in their kids, which can then exacerbate these symptoms. All right, so now what I want to get into for the meat of this is the treatment modalities. I just want to point out ADHD is treatable, but not curable. Although there are strong biological and genetic influences, behavioral interventions do have a very positive impact. Also, ADHD is not due to a lack of skill or a lack of knowledge, but it's really this problem of sustaining attention, effort, and motivation, especially when consequences are delayed, weak, or absent. And so what this means is that youth and adults with ADHD often need more structure or more scaffolding and more frequent and salient positive consequences. So stimulants have been around and used to treat ADHD for a while. I'm sure many of you are familiar with all of the different formulations. They're proliferating as we speak. There's all sorts of delivery systems that are continuing to be modified. All of these drugs we think work by altering dopamine activity, particularly in those frontal striatal brain regions. And they may help normalize some of the structural abnormalities and functional connections that then allow execution of different tasks and behaviors to proceed more efficiently. The effects, stimulants are very fast acting, so the effects are temporary. And what a lot of the randomized control trial research has indicated is they really only stay present while medication is being taken. So they're very beneficial in the short term, but there are questions about the long-term benefits, especially if medication use isn't continued. And as I'm sure all of you are aware, there's a lot of controversy about potential misuse of these meds, not necessarily among people with ADHD, but others misusing their stimulant medications or individuals with ADHD diverging their medications to others. So there are many other options, including noradrenergic drugs, antidepressants, SNRIs in particular, and different antihypertensive meds. One thing that I want to point out, though, about misuse or about medications is there's not strong evidence that medication use by children increases the risk for substance use problems. In fact, the evidence really shows the opposite. The kids that are not treated, kids with ADHD that don't receive treatment, are at increased risk for substance use. But there is evidence that individuals with ADHD may experience the different effects of substances. They may be more sensitive to some of those effects. So it is a really important question to continue to look at, particularly in individual patient care, to try to understand risk for potential substance use and risk of divergence when using these medications. What do we know about their efficacy? About 75% of ADHD youth will show a favorable behavioral response to stimulants. Now, these response rates are somewhat smaller and more variable for adults. There is actually a study that came out last year showing that long-term stimulant medication actually has many positive effects on brain development. Many of those brain differences I talked about earlier actually normalize and look more like non-ADHD brains by the time people get to adulthood. There's not a lot of evidence indicating long-term negative side effects of continued stimulant medication use, but there are some marginal effects on growth. So those things need to be monitored. And across the board, we do see that, again, individuals with ADHD that don't receive treatment have worse outcomes on all measures than those that are treated with stimulants. As I'm going to talk about, stimulant medications and behavior therapies have similar effect sizes, so they tend to work about the same, but medications tend to result in more immediate improvements. Now, the primary behavioral strategy that's used for ADHD is a variety of different parent management training techniques, or PMT. And these are therapies where parents are taught behavior management principles and techniques for contingency management, using positive reinforcement. Parents are also learned to develop skills to reduce their own levels of arousal so that they can engage more consistently with their behaviors. And there's very clear evidence that parent management training is beneficial in the short term. But again, the long-term benefits are still being debated. When parent management training ends, we see some of the behavior problems begin to reemerge. When we compare medication and therapy, the most famous study is the multimodal treatment of ADHD study, which I think is in its 19th year of follow-up. It's also called the MTA. This was the original randomized control trial that compared stimulant medication, behavior therapy, and their combination to each other. The original treatment arm was 14 weeks, and then the cohort has been followed since then. There's no continued treatment provided by this study. They're just allowing what people do naturally to happen and then just documenting those things. In the original study, both the medication groups outperformed behavior therapy at the end of the treatment period, but behavior therapy improvements caught up in the 12 months following the initial study. But once we got to 3 years and 8 years out, none of those randomized groups differed. So they all essentially regressed to an ADHD mean, where their symptoms continued and were more severe than any of the community controls. So interventions work well when they're being implemented, but the degree to which they have long-lasting effects is much less clear. There are also a number of educational interventions. So family-based interventions often don't carry over to school. So school-based interventions have considerable empirical support. There's lots of different strategies that people can use, and generally these are good teaching techniques anyway. Many of our teachers in the community use these already. But I just want to point out that punishment is used sparingly because it really rarely is effective in promoting long-term behavior change. The other thing I'd like to point out with patients that I work with and also in my research lab is that youth with ADHD often experience challenges in the classroom. They often receive a lot of messages that they are not doing well. And so it can be really beneficial to allow these kids opportunities to develop their talents and to achieve mastery at things. So when I talk to parents, I really try to consider not making participation in extracurricular activities, whether it's sports, music, art, any hobby activities, dependent on how they perform at school. Effort is still important, but making sure that they have access to these things, even if they're struggling in school. For teachers, helping students find the subjects and activities that are exciting to them, that give them opportunities to try new things out. And there's lots of evidence to support this. My colleagues at the University of Vermont have found strong evidence that involvement in activity of any kind, whether it's music, sports, art, computers, any types of club, is hugely beneficial for kids with ADHD in terms of boosting their well-being and their self-esteem. The picture that I included here is very purposeful. This is Michael Phelps, who was diagnosed with ADHD, pretty severe ADHD when he was younger, and found that swimming was just this wonderful outlet for a lot of the energy that he had, and it also allowed him to develop ways of structuring his time and his discipline and allowed him to be successful. And I think that that is a really great, not everybody's going to be Michael Phelps, but allowing people opportunity to find and harness and develop their talents is really important. There are also a number of intensive interventions. I'm not going to go into too much detail on these. There's multiple summer treatment programs that exist across the country. This is my colleague, Dr. Bill Pelham, he started the summer treatment programs. He unfortunately passed away at the end of 2023. But these are wonderful all-day summer camp programs that provide interventions for kids and also continue with academic work, so gains from the previous school year aren't lost. And these have been integrated into trials of medication, parent management. They've also included social skills training as well as additional educational interventions that have been really beneficial. There's also more intensive interventions like the child life and attention skills intervention that can be very helpful, that involves both parents and teachers. There's also wonderful support groups. I just want to point out CHAD, Children and Adults with ADHD, is a wonderful advocacy group that has a lot of great information that I usually direct folks to as well. And I'm going to talk more about some of the specific evidence-based behavioral treatments that focus on things like time management and mindfulness in a bit. So what about the developmental considerations in all of these? What are some of the take-homes that you all can have? So I'm taking all of this from the American Academy of Pediatrics. These are their clinical practice guidelines for ADHD. So first is to initiate an evaluation if you have a patient who's presenting with these symptoms to evaluate for ADHD. And generally this means confirming presence of those symptoms based on reports from multiple people. So parents, teachers, other caregivers involved with the child, and if the child is old enough, their own self-report. You also want to see evidence of academic or social impairment that results from the symptoms. And then most importantly, evidence that the symptoms and impairment are present in at least 2 different settings, so home and school. Providers should also at least screen for comorbid conditions, things like depression, anxiety, disruptive behavior, learning, even autism. Refer out to specialty providers if you need support there. And part of that is just determining whether or not these symptoms could be better accounted for by another problem. These are some of the measures that I think are best to use in these contexts. So there are broadband scales like the Achenbach, which assesses multiple different areas of functioning and behavior. The one thing you'll see highlighted across all of these is these are normed, and that means that they are comparing those teachers or parents' responses to a large normative sample. And this is really crucial for understanding how kids are comparing to their age mates, right? We want to understand if their behavior is outside of the norm of what would be expected at a particular developmental level. The Conners 4 is great for assessing ADHD as well as disruptive behaviors. It also has elements that ask questions about learning issues, peer functioning, and social functioning. And all of these have parent report, teacher report, and self-report versions. Then there are ADHD specific scales. I think the Vanderbilt is most commonly used in primary care. It is freely available to use. That is a great place to start when you're doing that initial screening. It is also normed for kids ages 6 to 18. And there's also a preschool version that is normed for kids as young as age 3. For toddler and preschool children, I think supplementing ADHD screening with additional measures of things like language, motor, and socio-emotional development can be helpful. Many kids with ADHD will have some delays in one or more of these areas. So things that I've used, and I think are frequently used at UHC, include things like the Ages and Stages questionnaire, the brief early childhood screening assessment, or even the Bailey can be very helpful. And again, getting rating scales and reports from caregivers as well as daycare providers and parents is all great. It's important to keep in mind that regulating behavior is an emerging skill for toddlers and preschoolers. And there's a lot of variability and a wide range of what is typical, right? So getting those normed measures becomes really important. In terms of adults, a clinical interview and self-informant rating scales that measure ADHD symptoms and impairment is important. So wanting to get self-report as well as report of another person. Keep in mind the threshold goes from 6 to 5 symptoms. And it's crucial to also assess particularly anxiety and depression symptoms because many of those actual symptoms overlap. And for adults, you need to consider the age of onset. Now, people don't need to be diagnosed in childhood, right? But they do need to have an onset of symptoms before age 12. And this is important because many of the adults that I see did not have access to care as kids. And so they don't have to have a diagnosis, but we do want to see evidence that symptoms did start before they were 12. There are a number of very helpful measures. I use the Barkley rating scales. Again, these are normed for both current and retrospective reported childhood symptoms. They also have scales that measure things like executive function and impairment that are also normed. So I usually combine the Barkley scales with the Achenbach, the adult self-report, to get all of that information. And for kids or adults, a multi-informant approach is really crucial, that we want patients and informants to provide ratings of both childhood symptoms retrospectively and current symptoms. Some other considerations, there's little evidence that additional cognitive or neuropsychological testing does anything in predicting diagnosis. The one exception that we found in my lab is a continuous performance test can be very helpful for distinguishing ADHD from depression in adults. It's important to include some assessment of effort or potential malingering when people are seeking diagnosis for things like accommodations or access to medications. And for women in particular seeking this diagnosis, it's important to do a careful evaluation of depression, particularly going back into childhood, trying to understand that many women with ADHD may not experience impairment due to their ADHD symptoms until later, until adolescence or adulthood. And one trend that's happening in the field right now is we're seeing a huge increase in diagnosis following the birth of the first child because of just the increased cognitive demands. But many people may not be diagnosed in childhood for a lot of reasons. My lab has found that individuals that have strong IQs or cognitive skills are likely buffered against any kind of academic or learning issues that develop. Having low hyperactivity symptoms, like many girls do, or low disruptive behaviors means that the symptoms are just less noticeable, particularly in the classroom. Kids that have strong social skills are often buffered against having problems with teachers or peers. And then kids that have really involved parents who provide a lot of support and scaffolding are often prevented from experiencing any impairment, even when they do have symptoms. And then they really have a hard time when that scaffolding goes away, which is why we see a lot of interest in evaluations when kids get to college. So in terms of treatment guidelines, the first line treatment for kids is parent management training and or classroom management training. So the first line treatment for kids ages 4 to 6 is not medication. If there's not moderate improvement or behaviors continue, then you can consider a methylphenidate, but you need to consider the risks and benefits of starting a stimulant before age 6 or delaying treatment. For school age kids, 6 to 11, the first line treatment is a combination of an FDA approved medication along with parent management training and classroom-based intervention. So it's really a three-pronged approach. I tend to call it the all hands on deck approach. And the classroom-based interventions can involve individualized education plans, 504 plans that provide other behavioral supports or accommodations. The recommendations are that providers titrate doses to achieve maximum benefit with tolerable side effects. And then, of course, consideration of things like cardiac health history, tics, impact on sleep, appetite, and growth are all very important for medications. For adolescents, 12 to 17, using medications and combined with therapy with adolescent assent. And then evidence-based treatments for things like anxiety and depression, and continuation of any school-based interventions. And again, titrating doses and consideration of other factors that can lead to negative side effects. What about adults? The treatment guidelines for adults are kind of slow to roll out. The first line treatment is medication and a cognitive behavioral strategy. But with medications, there's important need to consider the risk for misuse, for divergence. So for adults, most providers will do just a 28-day supply for their prescription. I know in the last year it's been challenging because there's been a shortage, particularly the Adderall shortage. But long-acting stimulants tend to be used more frequently, the extended release, things like Adderall and Vyvanse compared to controlled release substances. What I do tend to see with meds with adults is sometimes they'll do an extended release during the day and then a controlled release kind of for afternoon coverage. But a non-stimulant, if there's a history of harmful substance use, so atomoxetine and bupropion are most commonly used, keeping in mind that things like guanfacine and clonidine have only been FDA approved for children with ADHD. And then most importantly, monitoring treatment response in people with ADHD, and if they have a poor response or no response, to kind of reassess or try something else. There's two very strong evidence-based interventions for adults with ADHD. One is CBT, which focuses on building strategies to improve things like time management and organization. There's also mindfulness-based interventions that focus on building self-present moment awareness and emotion regulation. There's emerging evidence that these interventions may be more effective than medications in adults. There's also evidence that medications may be more effective in children than in adults. So again, those developmental considerations may be important. Adolescents and young adults tend to develop tolerances to different preparations of stimulants. They may have more rebound symptoms. So in my experience, many adolescents and adults ask frequently about or seek out alternatives to meds. I also wanted to talk a little bit about alternative treatments that are outside of these guidelines. So frequently what I've seen are things like restricted diets, allergy treatments, medications to correct inner ear problems, vestibular stimulation, exercise, yoga. So these have all been studied, and the findings are variable. So some studies find positive effects, other studies find no effects. And so I wanted to give you a sense of how I navigate some of this literature. And so what I've seen from the most recent meta-analyses is that dietary adjustments, so things like removal of synthetic color additives, flavors, preservatives, may be effective when families are motivated and when meal times are not an issue, right, where there's not other types of things, and when youth are generally compliant with parents. But keeping in mind that dietary strategies tend to have effect sizes that are smaller, so they have less of an effect on symptoms than things like medication or behavioral therapy. There's preliminary evidence supporting omega-3 supplementation that may have a positive effect on ADHD. Exercise-based interventions can be very important. This includes exercise and yoga. What they're affecting, though, varies across different studies. So some studies have found that they only show improvements in physical fitness and motor coordination, while other studies have found broader improvements in things like attention and academic performance. So I think bottom line when it comes to these is that if you have families who are motivated, if youth compliance with things are not an issue, then these can be helpful strategies to try. Other alternative treatments that are being developed, neurofeedback, which uses EEG and trains individuals to adjust their behavior in response to neural signals. These are showing promising effects. The question is about whether or not they generalize outside of the EEG setting, and they're quite expensive. Cognitive trainings are intensive protocols where kids practice different tasks to improve things like attention. Those findings have been positive, but they have been inconsistent across studies. And then I have some colleagues who are developing some peer-mediated interventions. So they're actually training kids to help other kids with ADHD, particularly with social skills and social learning. And that may be particularly beneficial for younger kids. And then there's ongoing trials right now looking at things like yoga and mindfulness meditation. And they have been helpful in with those kids and with adults with developing more adaptive emotion regulation strategies. So I'm just going to close with a couple brief comments on this because I know we're getting close to time and I want to make sure to get to your questions. One thing you may see more about is cognitive disengagement syndrome. This was formerly called sluggish cognitive tempo. These are symptoms defined by excessive mind wandering, mental confusion, and slowed down behaviors. They can be separated from the ADHD and attentive symptoms, and they are present in between 25 and 40% of people with ADHD. Importantly, these types of symptoms tend to emerge a little bit later in development, so usually mid-childhood, and they tend to get worse with age. And they tend to be highly linked to depression. So there's a lot of people trying to understand how things related to lack of focus or poor task completion or even comorbid problems can differ for cognitive disengagement versus ADHD. The bottom line here is that cognitive disengagement seems to be related to kind of a slowing down and more internal distractibility, where ADHD tends to be more kind of external distractibility and things with like executive functioning, not being able to plan or use working memory. Cognitive disengagement syndrome is not recognized as a separate condition in the DSM-5, and there remains a lot of debate, but I anticipate as things go forward, you'll likely see more information, more things coming out about CDS. And then lastly, this is something I deal with quite frequently. ADHD is a very hot topic. It might have brought some of you here today, which I think is great, but there is a ton of information, especially on things like TikTok now, with videos on ADHD routinely receiving in the millions and millions of hits. And so social media has become a powerful disseminator of good information and some misinformation. What I'm seeing is a wave of people coming in with self-diagnoses based on things they've seen on social media, lots of interest in therapies, lots of interest in accommodations. And it's been a very interesting pivotal point in my career. When I was a graduate student and junior faculty member, I felt like my goal was always to convince people that ADHD was real and caused issues for folks. And now one of my goals, I think, is to convince people that not everyone has ADHD. But I do think, you know, wanting to validate people's lived experiences while also giving them good evidence-based information and doing good screening, diagnosis, and treatment for folks is really important. What I also see frequently is family members of young adults with ADHD expressing concern about their transition into adulthood, their readiness for the workplace, readiness for independence. And again, where I think having important evidence-based assessment and access to interventions is important. Then lastly, I just want to close. I've talked a lot about deficiencies. One thing that I think we can do for folks with ADHD is help them identify their areas of strength. Many people with ADHD do show greater creativity and divergent thinking. They tend to generate more unconventional or novel solutions to problems, which can be really important. So finding those activities where their creativity and that individual responses are reinforced can be very helpful. Also in therapies, especially with adults, I try to focus on helping them build self-efficacy and confidence that they can complete tasks independently. People with ADHD may be very adaptable into fast-paced environments. So again, thinking about the person-environment fit here could be really important. Hyperfocus is something that some people with ADHD will experience, but I always caution that this needs to be balanced and that reliance on hyperfocus is unlikely to be a successful compensatory strategy in all cases, but that is something that people might experience. And so trying to help people draw out their strengths and build upon them is equally important as trying to identify their areas of weakness. I included in my slides some wonderful books. I'll make sure that these slides get a copy soon. And I'm happy to distribute these. These are fantastic books, and I have several resources, and thank you for your attention.
Thank you so much, Dr. Nikolas, for a fantastic presentation. And yes, I will send a handout of the slides in the follow-up email. We've had a number of questions come in, and so we'll dive right in. Can you speak about ADHD symptoms being mimicked due to excessive screen time and or early childhood trauma?
Yep, I think that's a really important point. So there is some evidence indicating that kids who previously had no symptoms of ADHD did start to develop increased inattention when they're exposed to more screen time. However, I want to point out that these are still low levels of symptoms that would not rise to the level of diagnoses, right? So you may see an uptick in some of these issues with screen time, but likely not that's going to push people into a diagnostic category. Early childhood trauma. So there's many aspects of ADHD kind of problems with, attention, organization, not seem to be listening to others that can also be influenced by things like trauma. So I think it's always important as part of, trying to understand if the symptoms are better accounted for by another condition. If you have a patient who's experienced a lot of trauma, trying to understand if some of the behaviors they're experiencing are more trauma related or sequelae of the trauma as opposed to things that may have existed prior to the trauma. So yes, both of those things are excellent points and definitely things that are important to consider in your assessment.
Thank you. Another question is, I'm struggling to differentiate between potential ADHD symptoms or sensory processing issues, seeking constant movement, seeking output and input of loud music or speech. Any thoughts or ideas?
Yes, I think that's a really great, and of course, those things are they co-occur. Many kids with ADHD also have sensory processing related issues. To me, I think the exact diagnostic piece is less important than how well the intervention works. And so if there are tools that can be beneficial for kids that have sensory processing related things, is to try them and to sort of evaluate whether the symptoms continue or not. What I see most frequently is the kids that have ADHD and sensory processing, as though some of those interventions will help with some of those things, but many of particularly the inattention symptoms tend to persist. But so I think including some of those interventions can be very helpful, but at the same time, I think we need to focus on, at least for ADHD, trying to focus on some of the other types of contingency management in the whole environment so that kids are also experiencing more positive reinforcement for the behaviors that we want to see.
Great, thank you. We'll try to do one more. What does the research say about retained primitive reflexes and having ADHD? Is there a relationship?
This is a very controversial area. It's a great question. And I would say the literature is quite mixed. There are definitely some studies that have indicated that this may be sort of part of the reason that ADHD has continued to sort of retain some of these reflexes. Other studies have sort of debunked some of those findings. So I would say I think that there's probably an ongoing question that where that needs to be addressed more specifically, and particularly with kind of better measurement. I think there's been a lot more kind of conceptually discussing some of those issues with less measurement, and so. But I do know some colleagues that are working on some of those things right now.
Wonderful, thank you. Well, it looks like we've hit 1 o'clock. We could definitely, I wish we would have planned a double part session so that we
I
can continue this
know.
discussion. But thank you everyone for all the wonderful questions that you submitted. I'll close with a couple of housekeeping announcements. The University of Iowa Carver College of Medicine is jointly accredited to provide continuing education for physicians, nurses, and social workers. All other participants will receive a certificate of participation. Attendees are eligible to claim continuing education credit by completing the evaluation and downloading their certificate of participation. The step-by-step instructions on how to claim credit are in the handout section or in the chat section. And I will also send this information in the follow-up email after the session. For any questions, please feel free to reach out to me via email. My email address is kafi, K-A-F-I-Dixon @uiowa.edu. So in closing, I just want to thank Dr. Nikolas again for a great presentation filled with information, and thank her for being willing to share those slides. So you have those as reference. And I would also like to thank you all for attending. Have a great afternoon, everyone.